I used to qualify for Medicaid. I now no longer qualify for Medicaid. I need acute care. I have all kinds of healthcare needs, and I'm part of the 10 to 12 million who no longer qualify. What happens to me?
HR1 is going to rip through our healthcare system and affect people who don't even know they're going to get affected by it. It's the $1 trillion cut to Medicaid. It will just drop people from coverage, and it could be dropping people that are meant to be covered, that are eligible for Medicaid, which means they could have disruptions in their care. They could lose access to services. You're going to see a ripple through our healthcare system that will affect close to 800 rural hospitals that are at risk for closure, some immediate risk. Even if they're not fully closing, you're going to see a trend that hits labor and delivery departments closing, emergency room departments closing. Whether you have Medicaid, you're uninsured, you have Medicare, you have private insurance, those cuts to Medicaid can lead to you not being able to go to the emergency department because that emergency department may cease to exist.
I'm joined by Kristi Martin. Kristi is the director at Camber Collective and previously an individual with a lot of CMS and Department of Health experience as the former chief of staff and senior advisor to the deputy administrator at the Center of Medicare at CMS, along with several other government positions. And you've worked with senior politicians in the past. You worked for Senator Waxman for quite a while, so always involved in the large healthcare policies that have been enacted over the past 15 years, from ACA to the Inflation Reduction Act, with a particular focus on drug pricing for Medicare, which is really, as I spoke to your former colleague before about Mina, transformational change in the US, which I think a lot of us will only come to appreciate over the coming years because it's relatively new. So just a pleasure to have you, Kristi.
Thank you so much. Thanks for inviting me to be on.
My pleasure. I should turn up my volume. Okay. So my first question to you is the environment that we're in today is tumultuous, to say the least. And most recently with this BBB bill that was passed, I think that's still the name that everyone's referring to, a significant increase in the Medicaid threshold, which many are estimating will result in the disqualification for Medicaid for a large number of our populace, 10 million plus, 10 to 12 million is the estimate that I've heard. What does that mean? I mean, and let me frame the question a little bit more specifically. I used to qualify for Medicaid. I now no longer qualify for Medicaid. I need long-term care. Long-term care, as we know, is a Medicaid program. It's not a Medicare program. I need emergency care. I need acute care. I have all kinds of healthcare needs, and I'm part of the 10 to 12 million who no longer qualify. What happens to me?
Yeah, I think let's just start off with the only thing I agree with about the bill's name is that it's big. But HR1, what is now law, is going to rip through our healthcare system and I think affect people who don't even know they're going to get affected by it. So let's talk about what's in it. So first, it's the $1 trillion cut to Medicaid, which is mostly on the back of work requirements that are going to be arduous. And we know from experiences in Arkansas, as well as the experiment in Georgia that's happening right now, it will just drop people from coverage. It actually doesn't save money because Georgia's experience are actually spending more money doing the verifications than they are saving money dropping people from coverage. And it could be dropping people that, are meant to be covered, that are eligible for Medicaid, which means they could have disruptions in their care. They could lose access to services. So that's one piece of it. Another piece of it is because of the cuts to how we're financing Medicaid, you're going to see a ripple through our healthcare system. That will affect everyone. And we're talking, close to 800 rural hospitals that are at risk for closure, some immediate risk. And even if they're not fully closing, you're going to see a trend that we've been facing for the last 10 to 15 years of labor and delivery departments closing, emergency room departments closing. And so whether you have Medicaid, you're uninsured, you have Medicare, you have private insurance, those cuts to Medicaid can lead to you not being able to go to the emergency department because that emergency department may cease to exist. Or maybe you can have a baby in your community and you're driving 3 hours in Northern California to go to a birthing center or to go to labor and delivery. I think the third piece of it, and I think this is the thing that I'm most worried about, is there's the cuts to Medicaid, the loss of health insurance that's associated with that. There is not the extension of the enhanced premium tax credits for ACA plans, which means more people will become uninsured as a result of that piece of it. And when you drop people from coverage, when they do not have coverage, the risk pool becomes higher risk, more costly. Those people still get care. They just get care through emergency departments, or they get uncompensated care. And then those get built into the rest of the people who have coverage insurance rates. And so we're going to see insurance rates continue to rise probably pretty drastically. So, I think like regardless of if you're on Medicaid right now, if your kids are on CHIP, if you have private insurance, we're all going to feel this
Right.
within a matter of a couple of years.
Yeah, we've been here before. We were here before ACA with 60 plus million uninsured that went down to 25 post ACA.
Mm-hmm.
And so I always think about it at a very practical level. I qualify for Medicaid one day, I'm in a nursing home, I'm 80 years old. All of a sudden, I don't qualify for Medicaid. I mean, the threshold requirements are work related. So I'm not sure that they've made it any more difficult for an 80-year-old to get long-term care.
Well, even bigger than that, long-term care.
So maybe a better example is the 40-year-old who was on Medicaid and no longer qualifies because they're not actively pursuing work or participating in community service. I'm just trying to think about it at a very unit level, individual level. Who's no longer getting what? I mean, emergency room care 20 years ago, we had 60 million people that relied on the emergency room solution. Those rooms were full. It was sort of the everything store for care for the uninsured. Non-profits, they picked up a lot of the slack. They're going to be relied on again. The for-profits will pick up through premium, and then this whole like black market of uncompensated care, sort of the calculation, I'll make it up on this end, but provide free care on that end. So that confusing reality gets pronounced. But just work with me, Kristi, at an individual level, what will I notice as significantly different as a patient who once qualified for Medicaid no longer qualifies for Medicaid?
Yeah, so let's stay on long-term care services and supports. So Medicaid is the largest payer of long-term care services and supports, mostly providing nursing home care, home and community-based care, lots of different versions of this so people can stay in their homes, or if they need to be in an institution, they can be. Medicare pays for very limited post-acute care benefit. So it's an optional benefit for states. So if states need to cut, we saw this happen in the recession, the 2008 recession. If states need to cut Medicaid rolls, if they need to cut their spending in Medicaid, the first place they're going to go is long-term care services and supports. And so that means somebody could still be eligible for Medicaid, but maybe they lose their home health aid. Maybe they lose their food delivery service. Maybe they lose their transportation service to their doctor. Maybe they lose, some type of rehab services. And so we're going to see it play out over several years, and states are going to have to react on how they're going to do it, how they're going to think about it. But with long-term care, last time we saw this type of like magnitude of cuts that were happening in the Medicaid program, and they were nowhere near 1 trillion, but they were pretty significant. Every single state Medicaid program cut long-term care services. Every single one.
So it's not an optimistic case of the money that I save on no longer paying Medicaid for a 40-year-old who qualifies for work, I'm going to redirect those funds to long-term care and augment the level of service for my 65.
No, they're cuts. It's not about moving money around on the table at this point. And states have to balance their budget every year. So they're going to have to figure out how to make up the money. And if they don't make up the money, they'll have to make some sacrifices on it.
Yeah, it is interesting the way Medicaid is structured, which is part state funded and usually 50% federal funded. So you're losing a lot of federal funding there.
Yeah, and some states go 80%. Like some of the poor southern states get 80 cents on the dollar for their Medicaid. And I think
take the point that we've seen now that the light is being shone on a lot of things that actually, and you probably have known this for a long time, the states have used federal Medicaid funding in creative and flexible ways to plug budget holes in healthcare for the uninsured and for other initiatives for years. So they do sort of view the federal component as a bit of a pot, rightly or wrongly. And so if the pot shrinks, your point is everything is likely to shrink.
Yeah. If the pie gets smaller, everybody's piece of the pie has got to get smaller too, proportionate, right? And so if the federal government is cutting funding, But then they're also restricting the ability for states like the provider taxes, state directed payments, changing the way states are actually helping to like bring more money into the program. The math won't work.
And before I get into sort of the other side of the coin of what we should be spending from a budget standpoint, also worth highlighting, and I'm curious to hear your thoughts, how anyway, as long as there's some wiggle room for interpretation and action, you get a wide variance in Medicaid spending that already exists in the system on a state-by-state basis. So Texas Medicaid coverage is 16% for people up between age 0 and 64. And to just give you one example, California is 28%. I think that California has a significant difference in income disparity, right? So this is a question of elective Medicaid coverage by state regulators, the adoption of ACA more broadly or less broadly. New York has 30%. So almost twice as much Medicaid coverage in New York versus Texas. Texas at 16.6% total. So we're already at a place in our country where, depending on where you live, you're going to find it relatively straightforward to get Medicaid or almost impossibly hard, right?
Right. And I think also, what are the benefits of the Medicaid program? States have a lot of flexibility right now within the waiver program. And California is a good example. California provides a very generous family planning contraception benefit within their Medicaid program. Because at the end of the day, if they're providing contraception, even beyond their typical Medicaid population, that means that they're avoiding maybe higher costs down the road with high-risk pregnancies. Medicaid pays for most of our pregnancies and deliveries in this country. And so, some states are using Medicaid as a way to emphasize preventive services, to support public health and prevention in their state. And some states choose not to do it that way. Some states use Medicaid as more than just a payer or coverage tool. They really use it to try to manage their public health and their strategy around their public health.
I almost feel like part of the challenge here, Kristi, is we're living in two countries that are pretending to be one. And we've got one country that is very much European model, happy to provide significant welfare and benefits and protections for its populace at significant expense, the good, the bad, and the ugly, right? When it works well, it's genuinely helping a lot of needy people who need the help. When it works badly, inefficient and fraud and all the things that are subject to criticism. Then you have the other country that's living in this country. Doesn't really feel that excited about huge, large welfare programs. And I want to get to this question in a second. Probably makes the argument, we're already spending $5 trillion north of $5 trillion on healthcare in this country. Half of that is coming from the government. What do you want from us? I mean, we have our own balance sheet issues, and enough's enough. We're doing more than everyone else across the world. We spend more than everyone else. We're told off for spending too much on healthcare, 17.5% of GDP. Surely we can make significant cuts. And both parties seem right to me, which makes it very challenging. The French provide tremendous long-term care benefits, and they provide tremendous employee benefits as well. But they underinvest in other areas. So it always feels like, and I'm just using the French, the English are another example, overinvest, underinvest. Every one of these countries that we look at overinvest somewhere relative to their peers and underinvest elsewhere. So what is the answer here with a federal government that is $37 trillion in the hole, with national debt growing at $1, $2, $3 trillion per year? What would you do if you were in charge differently?
So, I think a couple of things. I do think we have a system that's like a Rube Goldberg machine. There could be a lot more efficiencies. I think we could be smarter on our spending. I think people could get the care that they want and that they need, and the care that's evidence-based, and we could do it in a much more streamlined way. Medicaid is one of the most efficient payers that we have. Medicare is also one of those most efficient payers. Tackling kind of what is going on with our public and our private healthcare system. The commercial prices are very high. A lot of that is attributed to mergers and acquisitions, consolidation within our markets just not generally working. And so I do think that there can be changes there. One example, which was on a policy that was on the table, and it's small, but it's important, is site neutral payment. Why are we paying different prices for a colonoscopy if it's given in a hospital setting or an outpatient clinic? It doesn't make a lot of sense. And I think like European countries kind of figured that part out real quick. Like, they pay one price for things. They don't pay different prices for different things that are not attributed to value or outcomes. So I do think that we could be smarter about our healthcare. I think that was kind of the genesis of the Affordable Care Act, to be like, we can figure out how do you get people coverage and how do you provide the services they need, and then how do we shore up our system. But we forgot to kind of work on the prices part of it. So
So
we
I
worked
think
on the wrong part.
a lot of wonderful points there from you. I think that firstly, one thought that comes to mind here is even the comparison of spend on healthcare is confused because it typically excludes long-term care.
Mm-hmm.
So, when we look at France, 10 to 12%, the US 17.5%, that actually excludes the long-term care component, which is in addition to that. But back to your point, Medicaid and Medicare are actually efficient spenders. And that rings true to me. I mean, all the different healthcare providers that I've witnessed, been part of over the years, Medicaid is usually the lowest payer. And clinicians and provider groups are usually working their hardest to take care of Medicaid patients for the least in return. And so efficient. And it brings me to this question of unintended consequences in healthcare. I think you mentioned one area of improvement, which is disparate pricing, opaque pricing, and poor negotiation, which I think a lot of us intuitively know is part of the issue that we have in the US and partially addressed by you in the Inflation Reduction Act, which we'll get to in a second, with Medicare now negotiating drugs. I'm amazed that it took this long, but thankfully we're on our way now. But I think what you end up with is a long list of things that we can improve, right? Fraud and abuse, transparency, uniform standards, uniform pricing, a lot of things that we can improve. I would put them all on the list, and then I would add another column called the potential unintended consequences. And then you end up with the net result or anticipated result. And I think if you look at, taking 10 to 12 million people off Medicaid and significantly reducing the Medicaid component that federal governments are responsible for across state lines, you probably have a significant potential unintended consequence as you move from 25 million uninsured to 60. And so I would be a little cautious about that one. That change seems quite scary to me. And yet we have these other changes available to us. And then the other point I would make is, how many of these changes do you want to make within a 12-month time frame? Because it is a pretty fragile system, and I'm not sure it can withstand all these changes happening at the same time. So given all of that, so transparent pricing, let's focus on that for a second. And negotiations, you were heavily responsible, along with Mina, in producing and seeing through this Inflation Reduction Drug Pricing Act. What can we expect to happen as a result over the next 5 to 10 years?
So I think a couple of things that are important to note with Medicare negotiations, drug prices. One, 40 years in the making, which is very exciting. Two, Medicare, to your point, does set benchmarks. Other payers use Medicare, and we know this, right? We know certain states are implementing reference-based pricing. We know that Medicaid uses the payment for physician-administered drugs that's calculated by Medicare. So if we're negotiating the drugs that are the most expensive and sometimes most utilized in the country, we're publishing those prices, which is key. Because I think part of the problem with our system is that you mentioned the opaque, but it's a black box. Like when it comes to prices, it's so hard to figure out how much something costs, how much it should cost, how do you assign value to it. And I think that negotiation's starting to kind of crack the lid open on the box and say, like, okay, we've negotiated. These are the things that we negotiated on. This is the clinical value we think this drug has, and here's the price. And that those prices will start to get embedded. And I think that mindset of like negotiating for value, and I think value in a positive term, not like the Walmart value, but is this drug really innovative? Does this drug make a difference? Does it improve a patient's experience? Does it mean they have fewer hospital admissions or emergency room visits? I'm hoping that this is the start of like changing how we're paying for drugs in this country.
You would think so, given how important Medicare pricing is for delivery of care, right? It's been the anchor setting pricing for decades. So any reasons why it wouldn't fill that role in drug pricing over the next 10 years? Do you see any risks in the outcome?
Yeah, and I think that's a fair question. Part of our drug pricing problem in the US is manufacturers set very high prices. They can. I mean, it's a free market. And they have a lot of protection in terms of monopoly power through patents and FDA exclusive market exclusivities. But then we also have a lot of people that are within the supply chain that are also interested in keeping those prices high, whether it's a wholesaler who's getting a percentage off the high list price. And so they get more money if they push a higher price drug through the supply chain, or it's a PBM who's like, oh, a higher price means I can get more of a rebate. I think that's going to still continue to be a problem, especially because we haven't really dealt with that issue. HR1 that just passed at one point did have some PBM transparency components to it, some provisions that would start to maybe constrain some of that, the rebate gaming that's going on. Those were stripped out. So I think we have a lot of work to do ahead of us on the drug pricing front. I think negotiation's a good starting point with Medicare, but it's by far not the only problem that we solve for or that we need to solve for. I think there's a lot of other pieces that we need to be thinking about and tackling. And to your point earlier, I'm a person who's very much supportive of incremental policy change. I think not only do you need to understand what policy changes are you making to the system and how's the system going to react to those, but you need to be able to evaluate policy as well. And when you make a lot of big changes at once, it's very hard sometimes to tease out, well, what is the unintended consequence linked to? Because you've made so many changes.
Yeah. I think defining what you actually call a problem is interesting. I don't know that spending trillions of dollars on Medicaid and Medicare is in itself a problem. I don't know that yet. I do know that we have a lot of people to take care of in this country. Hence, therefore, I'm not racing to that conclusion. I do know that fraud and abuse is a problem. And I definitely know that inflation rates that are at 5 to 15% per year relative to income levels that are growing at 1 to 3% per year are a problem. Because what they represent is an ever smaller amount of savings, right? Everyone's pocket is growing at 1 to 3%, and something is grabbing the change out of your pocket at a rate of growth at 5 to 15%. That something is grabbing more and more money out of your pocket, therefore you have less and less. And that's been drug pricing and that's been hospital pricing for decades. So that would be interesting to me. Can we really target the elements of healthcare that are super inflationary and maybe not necessarily focus on the elements of healthcare that are not? I don't know that Medicaid was that inflationary. If you look at it on a per capita basis over the last 30 years, I would be surprised, given that it's such a low payer, that it was growing at 15% per year per capita. I mean, I haven't done the research. Do you have a sense of how inflationary was Medicaid over the last 20 years?
I agree with you. I don't think it was a driver of, inflation of
I know the hospital
medical
prices were.
Yeah, I mean, the reason why Medicaid hasn't particularly grown is because we are covering more people.
Oh, for sure. I mean, that's a huge point. Most people don't appreciate what America's population was in 1970. I think most people would guess 300 million, and now we're 350. No, I think it was 100 and change. Like it was, in fact, I'm going to chat GPT it, but it's a very different country. US population, 1970.
The baby boom, too. I mean, like we have a generation that is aging. More people are on Medicare than ever before. More people are dually eligible for Medicare and Medicaid than ever before. We're covering more people. And I think as we have been doing that, we're of course going to see spending growth. But I don't think that, to your point, I don't think that's bad spending growth. I think that there are areas where, if we look at drug spending in particular, that has really boomed since in the last 20 years. One point that gets made to me quite often when I was working for Henry Waxman was whenever the Hatch-Waxman Act passed in the 80s, there was one drug on the market that cost $1,000. Now you see drugs cost $1,000 every time they come onto market. The price of drugs has just inflated so much.
Well, that could be bias because the dollar has lost some of its value during the same time frame. It's not the same $1,000, but population, it was 200 million in 1970.
Yeah.
347, call it 350 million today. So almost 100%, almost a doubling. And so you have to factor for that as well when you look at these huge budgets. Our economy is significantly larger today than it was then. So there's going to be a lot more spend. What scares me is the rate of annual growth, because that inflation rate tells me which elements within our healthcare market are totally dysfunctional and disconnected from the rest of the country.
Yeah.
We cannot have an economy that grows at 1.5% or even 3% per year, and a segment within our market that's getting more expensive at a rate of 10%, 15% per year. Private education suffers from the same malaise measured over the last 30 years. And that leads to one outcome, which is significant frustration.
I think, the other thing that I think about often, John Oliver did an episode on his show maybe last year about medical education in the US. I mean, there's some fundamental differences from our system that I think are contributing to a lot of the things that we're talking about. If you are getting educated to become a doctor, doing training in a different country, you are not coming out with nearly as much debt as you do in this country. And not only that, but it's pushing people to go into specialty care. So we have fewer primary care providers. And at the end of the day, primary care providers are the ones who are lower cost, right? Catching things at the beginning.
But how do you
More.
justify it? How do you justify 10 years of health education for $250,000 annual salary
Yeah. Yeah.
with all the debt that entails? That's a
Exactly.
very good
Or
point.
go work in a community health center where you're going to get paid probably less, right? Go work in a place where there's not a provider, there's not a primary care doctor or a nurse practitioner or a physician's assistant. So I feel like we kind of talk about healthcare and like our pricing problem and our spending problem as it's a coverage problem, but it's actually a lot bigger than that. I think it's fundamentally how our system's been set up, the incentives in our system to push prices up to try to make the ends meet, having so many different types of players in the system. And so they're going to have, it's really hard to tell a publicly traded drug company that your price is too high when they are meant to be a profit maximizing entity.
Not
Right?
just the profit, not just the profit. One of the challenges we have, Kristi, is that everyone in healthcare has their excuses. Everyone.
Yeah.
Right? If you're a physician, you have your excuse because you spent 15 years in training gathering debt. So what do you want from me? Of course, I'm supposed to make money on the back end to justify all of that.
Mm-hmm.
If you're a hospital, you're taking care of the sickest, right? Mm-hmm. And if you're a drug company, you're given 3 years of patents, and then you have to be forced into generic land, and you've spent $1 billion to develop a drug. What do you want from me? Of course, I need to charge whatever I can to make sense of that. So everyone comes with their excuse. And then you have to somehow pierce through that, unpack it, and then reconstruct it in a way that makes sense. Talk to me about nonprofits and the role that you've played helping them along from a federal policy standpoint. What does that mean? Consulting, I imagine, to nonprofits, maybe lobbying on their behalf. Which nonprofits, in which direction? How do they fit into this ecosystem? It's an area that we don't spend enough time on, given how many of them are out there representing such a big chunk of delivering care in the US.
Yeah, so I was fortunate enough when I was in working on the Affordable Care Act that I met one nonprofit pharmaceutical company called Medicines 360 that was really focused on providing low cost contraception to safety net providers. And I feel like they were very mission driven. They understood that they were filling a very special niche in terms of providers who could not afford to keep a $600 LARC, long acting reversible contraceptive, on their shelves, waiting for a patient who might want it. So they were thinking, like, how do we actually get these products so that they're affordable for providers to have on the shelf? So if somebody says, yeah, I want that, that's the right option for me, they can deliver it. And I think it's trying to help them to kind of navigate what we've been talking about, right? Like, we live in a very complicated healthcare system. Where can they actually influence policy? And that could be at the federal level or the state level. How do they work within the system, within the parameters? How do they think about making changes to the system that could actually help them achieve their mission? I think the thing I've loved most about working with nonprofits, in particular nonprofit organizations, I worked at the American Cancer Society before the ACA passed, is that everybody's there purely for the mission. You are in those types of jobs because you believe exactly what you're doing is the right thing to do, for better or for worse. It's that passion and that drive is really important, I think, to some of these conversations. To your point, we have so many industries that are like, well, here's my pound of flesh. Like, this is what I need out of this. But nonprofits usually are coming from that in a very different mindset. And I think truly trying to solve some very specific problems that maybe we don't pay as much attention to as we should. So, I think the other thing too, I've worked with philanthropies in the past. And I think kind of the same thing on that front too, working with someone, philanthropy who's interested in engaging in health policy. You have the ability to start talking to people about like, well, what research do we not have to help inform the policy? How do we think about the economics of a policy? And really getting to that point where you're developing policy from the ground up that's taking in various perspectives, but making sure at the end of the day it's operational. So it's not just the blue sky version of the policy, but it's the policy that are like, oh, if this lands on somebody's desk, they can hit the ground running with.
So 50 to 60% of US hospitals are non-profit. The vast majority of community hospitals, non-profit. For-profit is 25 to 30%. Again, assuming, I mean, there are sources here from ChatGPT, but I always leave a disclaimer that it's ChatGPT, so anything's possible. Government-owned hospitals, 20%. And then if you look at ambulatory care percentage, non-profit, I wonder what the percentage is. 16% non-profit. So you've got a heavy focus on non-profit in the hospital segment. You've got a far smaller penetration in ambulatory, outpatient care centers, home health, behavioral health, but it's still a huge number. It's an insanely large number in the hospital segment. It's still a very material number in the ambulatory outpatient segment. And again, I don't think the average US citizen appreciates how big a role these non-government owned, non-government employed, they're simply non-profit entities that rely on other forms of funding, right, to keep the lights on. They rely on their grants and contributions. It's such an important piece of our industry. Is it a healthy segment? And when I think about it as an economist would, it's interesting in that it takes away a lot of funding pressure from the federal government and state governments, right? Because the funding is not exclusively reliant on those sources. It can diversify through philanthropy, right? And so it's asking the question of individuals and foundations, would you like to reallocate some of your savings towards our efforts, dedicated, focused, performance-oriented efforts? And so it's almost making the statement, we can't really rely on our government to do everything. And that is interesting that the US does that, because there are other countries that aren't doing that. There are plenty of examples of countries, especially in Europe, who have outsourced almost full responsibility of healthcare to their government. And there is no huge nonprofit category like this. So any thoughts?
I think even the range of the nonprofits, there's a lot of diversity there. I think if you listen to Senator Grassley over the last 30 something years, you will hear him rail about this quite often. And there's the nonprofits that are like that large academic institution ones, right? MD Anderson, Johns Hopkins, Memorial Sloan.
And they've really been successful. I mean, think about it as a business model. This is a business model that has thrived. Non-profit hospitals.
Yeah, and those are like research one institutions. They get a ton of government grant funding for research, for running clinical trials. Like they're really hubs of academic research and training, right? They have a lot of graduate medical education slots, so they're getting funding for that. And then you think of the small soul community hospital, and their margins are completely different, right? Because of where they're getting funding. So I think when we start to think about nonprofit hospitals, there's a lot of variation there. And you will see, we haven't talked about it, and this is super wonky, but there's a program called 340B drug pricing program that's run out of the Health Resources and Services Administration. At least today it is. And that program was set up as an unintended consequence response to the Medicaid drug rebate program. So when the Medicaid drug rebate program went into effect and required rebates from drug manufacturers, to state Medicaid programs to cover those drugs, what happened was that a bunch of hospitals and community health centers, nonprofit hospitals, lost deeply discount drugs because now all these discounts were going toward Medicaid. So as a result, they created the 340B program, which requires that those hospitals and those community health centers get cheapest drugs, like basically the best price you can possibly get on the drugs. And I think, if you look at the margins.
Was that nationwide, or that was elected by some states?
No, it was nationwide. It's a national program.
But another wonderful example of the unintended consequences of constraining Medicaid resources.
Yeah. And
because there's so many different pockets that rely on that Medicaid source.
Yeah. And the way that it works is that these hospitals and these community health centers buy the drug at a really low rate, but then they charge Medicare and Medicaid the normal rate, or private insurance. So then they make a little bit and they can reinvest that money into their system. But if you think about the really large nonprofit hospitals, like the MD Andersons, Think about the volume of drugs that they're pushing through their system, oncology drugs that are very expensive compared to maybe a small sole community hospital that has maybe 25 beds. And so, those types of dynamics matter. And I think that that's something else too. We kind of think of like, oh, there's nonprofit hospitals, right? There's for-profit hospitals, but it's actually, there's a lot of variation within those categories that we're not really
Of
thinking
scale and
through.
without scale, for
Yeah.
sure.
And like where they're located and like what are all their business lines? How do they think things? Like, a lot of the bigger hospitals have acquired outpatient clinics and practices over time. So they pulled in more revenue streams to help shore them up versus the community hospital that may be like running on a razor thin margin. And I think we need to think about that. We need to think about, instead of just categorizing like a dish hospital, disproportionate share hospital, because they see a lot of Medicare and Medicaid patients, do we need to really think about like, well, what's the business model of that hospital? Where is it located? And how do we start to think about shoring
So
up where we need
40
care?
years to manifest Medicare drug negotiations. Are we looking at the same timeline for a community hospital funding program coming out of the federal government? Because it sounds like that's what we need, right? We need an entire program that's just dedicated towards this goal of smaller hospitals in smaller regions serving smaller populations.
I think we do need to rethink the financing. I don't know what the horizon. I would say argue maybe it's 6 to 10 years from now. We may lose a lot along the way. But you saw a little glimpse of that in HR1, right? They had the Rural Transformation Fund, where they put $50 billion into a fund that could be eligible for rural hospitals and community health centers. And I think like that's the type of thing, that flexibility to really like, how do we think about financing different types of settings where we need care versus just paying for everything in one way. Medicare and Medicaid, I'm a huge fan of them, as you know. Like, I think very highly of those programs, but they were also created in 1965. So, like, I do think that when it comes to things over time, you always have to revisit and say, okay, does this model still work for where we are right now? For how we're delivering care or how we want to deliver care. And I do think that with rural health in particular, we've got to start rethinking how we finance it. Because I think that there are different push and pulls that need to be considered for a small community hospital than for a very large system.
I think so much of healthcare in the US is led by federal government reimbursement programs. It really is an example of the government in the lead. And it's interesting because there's plenty of opportunities for inefficiency and dysfunction in government programs. I have a close friend who is constantly negotiating for government contracts in healthcare, and it's ugly. Let me tell you, there's a lot of dysfunction there. But for reimbursement programs, we're not talking about government contracts. We're talking about setting policy and pricing with funding behind it nationwide. There is a lot of intelligence and value add that comes from these government programs that lasts for decades. You end up seeing entire industry segments built around programs and then leverage them. Like even commercial payers are leveraging the Medicare program and the intelligence that comes from it every day. So it's always been an exciting space interacting with professionals such as yourself who have been part of that. When you think about the next 10 years to come, and you think about virtual care and you think about artificial intelligence and technology at large and its role, its growing role in healthcare, rapidly growing role in healthcare. Do we have the reimbursement programs today to facilitate that correctly, manage it correctly, incentivize it correctly? Or are we looking at a whole other program that hasn't been designed yet, let alone manifested?
I think it depends on specifically what we're talking about. I'm an AI skeptic. It makes me very nervous. I see a lot of the negative of AI, I think.
Yeah, we're definitely we're in the euphoria stage.
Yeah. And I feel like, I worry about does AI double down on best practices versus worst practices because of what it is being fed, right? It's self-learning. So if you feed it certain things, what it spits out to you might be reflective of that, very much so. And so I worry about, how it could be used to actually harm patient care and patient outcomes to meet a bottom line. I do think that we need a better regulatory environment, just like health privacy. I think when HIPAA in the 90s when HIPAA came along, we really had to tackle how to deal with health privacy. And that's part of what HIPAA was. The other part was portability. And, I think we're kind of in that phase with AI right now. We have to figure out like, well, what are the parameters? What are the where's the fence need to be set that it can operate within before we can actually really think about the reimbursement piece of it. And I don't know that it is reimbursable. I feel like it might be more of like it's just a tool within the system than it's a reimbursable expenditure. I do have hope that like diagnostic tools and things like that could, that's where the technology I'm hoping is really going to accelerate. We'll get better diagnostic tools, we'll get better devices, treatments, and that's where maybe over time we can create some efficiencies. I do think that we're already seeing this with the cell and gene therapies that have come online. Medicare and Medicaid are not really set up to be able to reimburse those. These I'll call them boutique, but they're like personalized medicine. And our current system is really not set up to be able to reimburse that type of technology or that type of innovation. So I think there's a lot of work, CMM.
Certainly not set up to deal with preventative care.
Well, yeah, 100%. And I think that's a lot of that. I was just on a call earlier today and talking about how the Congressional Budget Office will not score prevention. And therefore, that's kind of been an issue with how do you build it in policy if they won't score it as a saver.
Isn't that amazing? We won't incentivize savings.
And it's because they work in a 10-year window. And most prevention, you don't see paying off for 2 to 3 generations, right? It takes a long time for that return on investment to show back up,
And decisions like that only widen the gap between those who are engaged in preventative care, self-funding it, extending their lifespans, and those who are reliant on the government to assist them, and there is no assistance. So the variance widens.
Yeah, and I think, a good example is smoking cessation. Smoking cessation was not covered before the ACA. And that vaccines, there's certain things we know will save money in the long run, will improve people's health outcomes, right? And we're just not equipped to be able to build those into our system and really support them. And I think some of it is there's a public trust problem as well. Like, I think, a lot of this is like, there's all these caveats. Like, I think that's what makes healthcare so hard is that there's no like one answer to any question. There's here's the answer. And then, by the way, here's some footnotes, right? Or here's some caveats to that answer. And I think we really need to be thinking about, there's the small pieces, the incremental policy changes we can make to improve how our system is functioning, to improve the market with which we're paying for healthcare. But there are some fundamental shifts that I think, some of the MAHA movement is working toward of like, we also need to rethink health in the country.
Yeah. I think that movement is healthy. I'm a big proponent of that. I don't know if I'm signing off on all things MAHA, but I am underwriting there's a difference between health and healthcare.
I get all that.
And I think just that sentence is very healthy. Say again?
Yes, I get all the vaccines. I'm a huge supporter of vaccines.
So that for me is sort of secondary level.
Yeah.
And there's plenty of room for debate, agreement, disagreement, great. For me, just the primary level of health is not the same as healthcare is very interesting to me because I feel like we've overweighted healthcare in this country for the last 50 years, and we've underweighted this subject of health, as demonstrated by our food choices and as demonstrated by our exercise and preventative care. Preventative care is critical, and I worry that we're still going to be at life expectancy for a country 76, 77, less than that for men, more than that for women, not realizing that our life expectancy for those that are engaged in preventative care grows and grows, 85, 90, 95. And our life expectancy for those that don't engage in preventive care remains in the 60s. That is a strange society to live in, not aspirational.
Yeah.
So a really important topic. And when we talk about new government policies, looks like there's plenty of room for improvement there. On AI, I don't know necessarily that you just need to think about the economics of it, but also the behavioral aspects of it. How do you incentivize good AI behavior versus bad AI behavior? And who's going to do that if not our elected officials?
Yeah, I think going back to the the Obamas were really trying to promote, healthy eating and exercise, right? Like some very basic tenets of prevention. And I feel like, this is going back to where we started with Medicaid. Some of the things that Medicaid does is make sure that people have good food. They make sure people have transportation. They make sure people have health communities. There's so many of the things that, there's so many examples of where states have taken Medicaid dollars to actually improve community living. And those things are critically important. And the whole food is medicine movement, I think, has a lot of promise, but we've just got to make those things a priority, just the same way we're making a conversation about how much we spend on Medicare and Medicaid and private insurance a priority.
Kristi, I want to thank you for your time, and also I want to thank you for all your good deeds. It's a wonderful topic that you've picked to dedicate a career to, and you've made a lot of meaningful changes so far, and I'm excited for you to keep going.
Thank you so much.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.